Dear colleagues, I am Güldeniz Karadeniz Çakmak from Turkey. I'm a breast surgeon, and it's my great pleasure to be with you. Although, unfortunately, under the shadow of COVID pandemic, this year's San Antonio Breast Cancer Symposium hosted very hot topics regarding translational, basic, and clinical science as usual. And I'm going to mention a group of selected abstracts related to locoregional treatment. Before discussing the presented abstracts, one mini symposium and one debate merit consideration to begin with. The evolution of local therapy in the genomic era was discussed by Monica Morrow and Philip Portmans. The question was, what should be the next extent of axillary surgery in the genomic era in 2021, which is the time we know that axillary surgery doesn't improve survival or local control with very robust evidence. So if the results of the sentinel lymph node biopsy would not change adjuvant treatment decision, can we completely omit axillary surgery in some subgroup of patients? When we look at the results of our Exponder and Monarchy, excluding premenopausal women, and ask the question, do we need axillary lymph node dissection for postmenopausal women with ER positive and HER2 negative disease with 2 or less node metastases to determine if our Exponder applies? The risk-benefit ratio for performing axillary lymph node dissection for this large subset of postmenopausal women was told as unfavorable. So what about the monarchy? When the same question is asked to select out particularly high-risk women that axillary dissection could be justified, the answer would be in patients with higher risk of additional positive nodes, like involvement of 2 or more nodes, large tumors, high-grade disease with lymphovascular invasion, are the combinational factors predicting higher likelihood of additional axillary nodal metastasis, where the morbidity of axillary lymph node dissection could be afforded and can be selectively performed, which was also highlighted by Dr. Morrow. Regarding radiation decision-making, it was highlighted that the presence of axillary nodal disease is regarded as an indication for locoregional radiation therapy in many settings. Today, sonographic evaluation is an efficient modality to improve our ability to exclude higher disease burden in axilla, and adding ultrasound to physical exam resulted in acceptable rates of axillary status prediction, which was demonstrated in SEMA and the SUN trials. So given the fact that sentinel lymph node biopsy is less morbid and less costly than RNA and post-mastectomy radiotherapy, Dr. Morrow emphasized the importance of sentinel lymph node biopsy over radiation that is given because of uncertainty about nodal status. On the other hand, she mentioned the post-negative rate of sentinel lymph node biopsy for node-negative patients, which doesn't lead us to radiate axilla, and told as a hope for the future that the data from the ongoing trials has the potential to alter current approach, which is irrelevant to the biologic risk factors, and radiotherapy is a must to all women with nodal metastasis, regardless of the disease burden. Conclusion remarks were in small clinical and super cancers, heavy axillary tumor burden is uncommon, and sentinel lymph node biopsy is not needed for local control. Nodal status is important for systemic therapy selection is post-NAC patients, ER positive, HER2 negative, premenopausal women, triple negative breast cancer smaller than 0.5 centimeters, but for the majority of the patients who are ER positive and postmenopausal women, nodal status is no longer the determinant of systemic therapy, but still the primary determinant of radiation therapy requirement. And Dr. Morrow concluded that the opinion that the genomic era offers the opportunity for less axillary surgery in a significant number of breast cancer patients, but requires acceptance of a greater amount of uncertainty than physicians have historically been comfortable with. The question for Professor Portmans was if it is possible to tailor radiation therapy according to genomic risk, which he answered with an elegant talk as usual, beginning with the fact that 20th century was a one-size-fits-all period for not only radiation therapy, but other therapy modalities as well. And the integration of molecular subtypes, molecular risk factors, and the signatures to guide decision-making process for the future was highlighted in the presentation. So during tailoring locoregional therapy, interaction between the systemic and locoregional treatments are of paramount importance that is evidenced with trials with longer follow-up periods. In the previous EBCTG meta-analysis, for high-risk patients without effective systemic therapy, low benefit from local therapy has been reported. 2005 paper from the same researchers revealed that for every 4 local recurrences prevented, 1 breast cancer death. And in subsequent analysis, one breast cancer death at 20 years was avoided for every 1.5 recurrences avoided at 10 years. Moreover, following studies reported more favorable results. But for low-risk patients who received highly effective systemic therapy, the radiation therapy benefits will be less. So Dr. Portmans asked the question that can the decrease in local or systemic therapy be considered for this subgroup of patients? However, regarding the primary question of tailoring radiation therapy according to genomic risk, he concluded that at present, a validated biomarker to accurately predict the patients who could benefit from radiation therapy in individual patient level is lacking, and current evidence is not yet robust enough to guide decision-making. But 21st century will be the year of individualized treatment approach guided by personal, molecular, and genomic factors, predicting local or systemic therapy necessity, tailored in a multidisciplinary attitude, and designed with shared decision-making manner. As a surgeon, I found the debate about 1 week of whole breast radiotherapy as a new standard of care very fascinating. As we know, hypofractionation is not a new concept with a history back to 1990s. The major point of this debate was to emphasize the 5-fraction 26-gray radiotherapy protocol, namely fast-forward, which was a multi-center randomized phase 3 non-inferiority trial, and the 5-year results of which was published just at the beginning of the COVID pandemic, reporting excellent data in terms of outcomes with a very short course, which would be the preferred way to approach the breast in terms of radiation therapy. But what about toxicity? It is acceptable at 5 years, but with the known long-term effects of irradiation, I guess upcoming years should be waited to make a strict decision on this issue. And to summarize, the debate focused on whether data over many trials has actually got us to the point when we need much less radiotherapy, but actually can be just as effective as conventional counterpart, which is now proven and supported by the strong scientific data. However, the slightly higher toxicity and longer-term outcome data is missing, and that we have to wait and see. With the question pending, is it going to be safe and efficacious enough in the long run? So we have the 25-year follow-up data of the efficacy of the conventional standard approach. For that reason, I think, as Dr. White also mentioned during the debate, there is some kind of caution required before offering it as a standard of care, but as an option for the patients, for the selected patients. And also, we need to wait for the additional prospective outcomes and the treatment planning data in order to minimize the harms to the patients. Due to the global pandemic, rapid implementation of this short course fractionation became necessary with major plus points all around the world, as we know, which may or may not lead to some global health benefits that we would witness in the future. And at the end of the debate, 5-fraction whole breast irradiation without reservations was recommended as the new standard of care by 68% of the responders to the poll. Moving on general session, we analyze the general, when we analyze the general session, the first abstract to be mentioned regarding surgery was SNODA-1 trial. This European study designed to look at the long-term oncologic outcomes of less versus more axillary surgery and hoping to give answers to some of the criticized points of Z11 trial. So what was the SNODA-1 is really searching for, and what was different from the American Z11 trial? When we look at the arms of the SNODA-1 similar to Z11, no statistically significant difference was found between the treatment arms in terms of recurrence and survival. When SNODA-1 is compared what Z11 demonstrated, we see that it's addressing some of the issues. The follow-up is for 34 months, which we know that most of the axillary recurrences took place. In SNODA-1, 20% of the patients underwent mastectomies, unlike in Z11, and detailed radiotherapy data was higher than 70%, which was really very good. And as a matter of fact, the important thing in axilla is macrometastasis, not the micrometastasis. So in Z11 with only sentinel lymph node biopsy, the recurrence rate was very low, ringing the bells for us, the surgeons, to rely on tumor biology guided systemic treatments than other treatment options. And as a matter of fact, there is no survival or local control advantage with axillary lymph node dissection for this group of patients. So the data from the ongoing trials will answer these questions like POSNOC and MI49 trial, randomizing T1 and T2 patients with up to 2 macromets undergoing lumpectomy or mastectomy to systemic therapy alone or plus axillary treatment with axillary lymph node dissection or axillary irradiation, asking the question whether or not directed axillary treatment is necessary for local control or survival. And MA39 Taylor RT trial, including similar patient population, which uses 21 gene recurrence score as a biomarker to identify low risk, not positive patients for whom we can omit regional irradiation. And as a conclusion, since we are in the era of discussing the omission of sentinel lymph node biopsy in selected patient groups, overlapping results supporting each other of Synodor 1 and Z11 is very convincing, encouraging, and for not proposed full axillary dissection to patients who fulfill the selection criteria. The second trial I'd like to share is the INSEMA trial. Patient-reported outcomes of INSEMA were reported regarding the impact of axillary surgery on arm and the breast symptoms. When we look at this arm symptoms as a quality of life parameter, even performing only sentinel lymph node biopsy has some kind of impact that we see with the green and pink lines on the left. On the right, we see that women, when compared to axillary lymph node dissection, sentinel lymph node biopsy has a lesser impact on arm morbidity, presented with the pink line, but I should emphasize it also has. So confirming the fact that any invasive procedure has some sort of impact on women's arm symptoms. So with the surgeons, as the surgeons, we should be very well aware of the fact that yes, sentinel lymph node biopsy leads to less morbidity, but it has a morbidity. So I'm very excited about to see the primary outcome data of INSEMA, which is disease-free survival, that are expected to be announced by the end of 2024 and would be, I hope, practice changing. The third study to be commented is a single-center study from New York, interrogating the impact of race and ethnicity on the breast cancer-related lymphedema following axillary lymph node dissection, with limitations of relatively shorter follow-up of 2 years and unable to assess independent effect of nodal radiation on the risk of lymphedema, as most of the patients included to the study received radiation therapy. Demonstrated in the figures with blue and green lines that in African American or Hispanic origin, when you have axillary lymph node dissection, your lymphedema rate is much higher, even in 24 months, and it is up to nearly 40%. In the multivariate analysis evaluating factors other than ethnicity that make lymphedema worse, researchers reported that neoadjuvant chemo had significant effect when compared to upfront surgery. On the other hand, factors such as body mass index, receptor subtype, number of positive nodes, or number of lymph nodes removed was not significant. These are crucial impacts that each surgeon should keep in mind. With the unfortunate higher lymphedema risk in specific ethnic origins, the exact underlying mechanism or the etiology by which ethnicity or neoadjuvant therapy resulted in greater incidence of lymphedema development seems to be a matter of future research. Moreover, the professions of the African American or Hispanic women with the lymphedema should also be evaluated regarding the role of overuse injuries that might lead to those kind of consequences. So moving on to the spotlight sessions, one of which was about the de-escalation of locoregional treatment in breast cancer, was of course very exciting. Beginning with the presentations related to radiation therapy, there are two abstracts I would like to mention regarding the escalation of radiation for locoregional control. First of which is a multi-center retrospective analysis from United States of the treatment outcomes of low-risk ER-positive early-stage breast cancer treated with or without radiation therapy by Dr. Seol and colleagues, entitled Avoidance of Radiotherapy for Low-Risk Early Breast Cancer Using Lumina Trial Criteria and Accounting for Endocrine Therapy Adherence. To identify low risk, researchers apply Lumina criteria. which is age older than 55 years, unifocal, unilateral, ductal, tubular, or mucinous histology, smaller tumors, lower grades, hormone-positive tumors, and negative margins. So with 110 patients meeting the criteria, 73 of whom was found to be endocrine therapy adherent, which means patients received 5 years of endocrine therapy or discontinued due to recurrence or death. 5-year locoregional control rates were compared across groups using Kaplan-Meier curves, and 5 years locoregional control rate for radiotherapy was 100% when compared to radiotherapy omission group with a rate of 94%. The difference was statistically significant. Subset analysis revealed that 5-year locoregional control rates for radiotherapy or radiotherapy omission was both 100% in endocrine therapy adherent group. However, in endocrine therapy non-adherent patients, it was 100% versus 83%, which didn't reach statistical significance. Non-adherence to endocrine therapy can vary quite largely in the literature, as we know. And this study shows that patients with very low risk early breast cancer, adherence to endocrine therapy lead to excellent local control without radiotherapy, which is exciting and makes us hopeful in terms of the escalating radiotherapy in properly selected subgroup of patients. One question coming to the scene is the role of endocrine therapy above radiotherapy in these low-risk disease. The second abstract is a multi-center prospective study from Spain looking for the answer to the question that can mastectomy be safely avoided after ipsilateral breast radiation therapy following prior breast conservation. Researchers selected 35 patients between 2014 and 2020 who underwent second conserving surgeries and accelerated partial breast irradiation for analysis. The median follow-up period was 37 months. They have a wide range of molecular subtypes, including 33% luminal A, 40% luminal B, 70% HER2 positive, and 10% triple negative breast cancers. And there were only 4 relapses totally. Only one was local recurrence in the breast that developed after initial non-invasive recurrence. 3 patients developed metastatic recurrence. 2 of them was luminal B subtype, not the triple negative or the HER2 positive subtype. And 5-year overall survival rate was found to be nearly 94%. And also molecular subtype was not found to be associated with worse outcome. We know that salvage mastectomy, there is also a risk of recurrence. So radiation following a second lumpectomy for the selected group of patients seemed to be an option. Before going to the next step, I would like to say a few words about this issue. In the absence of randomized data beyond single and multi-center prospective or retrospective analysis, the outcome data which prevents core mesh cohort analysis of the JAK-ESTRO VC working group database, which was published in 2021, reported not significant difference for local recurrence, regional recurrence, distant metastasis, and disease-free survival rates for salvage mastectomy and second conservative surgery, meaning that the oncologic outcomes of secondary conservations are equivalent to mastectomies. There is one more crucial point to be highlighted in the abstract of Espinosa and colleagues is that there is a great similarities regarding design and outcomes with the NRG RTOC 1014 trial. The NRG study has a higher rate of DCAs and lower rate of invasive recurrence, which might be due to the longer median follow-up of 5.5 years. And when we look at the data from Spain, ipsilateral tumor recurrence is 3% for 3 years and 5% for 5 years in NRG study, which is really encouraging in the accurate setting of patient selection. And coming to the abstracts regarding the escalation in surgery, which is my favorite topic as a surgeon, the first study to mention is from ACS Alliance D&I group, analyzing National Cancer Database, looking for transient surgical resection for stage 4 breast cancer. Surgery for stage 4 breast cancer is a hot topic, and there's a great wealth of data from prospective and retrospective trials are somewhat saying contradictory results or words and became sometimes confusing or recommending different options. So before commenting on this abstract, I would like to say a few things about metastatic breast cancer session in the San Antonio Breast Cancer Symposium and prospective trials addressing the use of locoregional therapy for primary tumor in INNOVA stage 4 disease, hoping to sort the confusion out a bit. So when we look at the completed randomized trials which are published, we see that there are 4 randomized published trials from India, Turkey, Austria, and North America. From Indian and just published North American study, the early locoregional therapy for the primary site didn't improve survival in patients presented with metastatic breast cancer. Although it was associated with improved locoregional control, this had no overall impact on quality of life as mentioned in ECOCACRIN trial. On the contrary, Turkish MF0701 demonstrated a survival advantage at 5 years with a hazard ratio of 0.66 in patients having surgery first. However, this was not supported by the data of Austrian trial, which with a much more small number due to the closing of the trial for low accrual before reaching the desired number of patients. This trial favors systemic treatment, but difference was not significant in the arms. A closer look to the discrepant results between MF0701 and ECOCACRIN, we see that MF0701 has more hormone-positive tumors and less triple-negative tumors in the surgery arm, and also has more bone-only metastasis. There were no statistically significant difference in 3 years, which was the primary endpoint of the trial. However, there is in 5 years regarding survival in MF07. The locoregional therapy arm achieved 40% of survival in 5 years in both studies. However, the systemic therapy arm reached 40% of survival in North American study, but it was 24% in MF07. So making the point that the difference in these trials are somewhat might be due to the outcome of the systemic therapy. So with all these data in mind, the abstract from Douglas and colleagues used National Cancer Database looking for the national trends in surgical resection and other therapies for stage 4 breast cancer. Between the period of 2004 and 2017, 9% had conservation therapy, 20% had mastectomy, with the remaining had not any breast surgery at all. And the trend of upwards using of surgery rose to 37% in 2009 and declined to 17% in 2017. What is interesting is that the largest decline was seen in hormone-positive tumors. And in 2004, the rate of systemic therapy alone was more common than the locoregional therapy, namely surgery and radiation therapy. However, by 2017, systemic therapy alone was by far more frequently used. Some subgroups experienced less surgery, but interestingly, patients with metaplastic cancer, triple-negative breast cancer, or who received radiotherapy were more likely to have surgery than the others. So the trend is unquestionably towards omitting surgery in stage 4 breast cancer in US. However, the question is to select right patients who could benefit from surgery or for whom the surgery may have some kind of value. And at this point, 2 recent publications merit consideration. I would like to complete this topic with these without entering details. The NCBD analysis by Stalk and colleagues noted a survival advantage for patients who received either systemic therapy and surgery or trimodal therapy with systemic therapy, surgery, and irradiation compared with systemic therapy alone, and concluded that surgery in addition to systemic therapy had a survival benefit for stage 4 breast cancer patients with known hormone receptor and HER2 status and should be considered after neoadjuvant chemotherapy for patients with hormone receptor positive and HER2 positive patients. The second publication is update of MF0701 with a 10-year follow-up of 265 women, confirming the previous outcome data, demonstrating an advantage for surgery with systemic therapy over systemic therapy alone. Median survival was 46 months for surgery and 35 months for systemic therapy arm, meaning that hazards of death was 29% lower in the locoregional treatment group compared with the systemic therapy alone group. So when we think about what to do in the future, it merits consideration to revisit the question to totally omitting surgery for stage 4 breast cancer. Instead, regarding the survival data of the recent publications, a more selective approach might be employed. Surgery after neoadjuvant systemic therapy for hormone positive and even HER2 positive disease may have some value, and the key would be to identify the patients who could benefit from surgery and make selection on case-by-case basis. Another hot topic regarding the escalation in surgery is axillary management, and of course, the omission of sentinel lymph node biopsy. As we very well know that our century witnessed great paradigm shifts through the escalation in breast cancer surgery, either in axilla or the breast. Fortunately, sentinel lymph node biopsy replaced axillary lymph node dissection for clinical node negative patients for staging purposes, and the evidence is overwhelming in terms of long-term oncologic outcomes. We have used sentinel lymph node biopsy increasingly over the years, and a study from Cleveland asked the question for older women that is it really safe to omit sentinel lymph node biopsy for all patients within this age group? In other words, in which terms there may be any value of performing axillary surgery for this selected group of patients, particularly when choosing wisely guidelines of SSO is in mind. The authors examined sentinel lymph node biopsy omission and outcomes using National Cancer Database and included patients older than 70 years with T1 hormone-positive disease who underwent breast-conserving surgery and endocrine therapy. They used propensity matching to avoid any other causes of mismatch or biases. The axillary assessment, as we know, is not always very clear in NCBD, but the ultrasonographic evaluation might be higher in recent years. The results unsurprisingly demonstrated that patients who had positive nodes are women with larger tumor, with lymphovascular invasion, and centrally located tumors. Those who had sentinel lymph node biopsy had more likely to have chemotherapy and irradiation. And the crucial point is omitting sentinel lymph node biopsy resulted in statistically significant decrease in overall survival for 3 and 5 years. So the conclusion is that axillary staging with sentinel lymph node biopsy impacts survival via decisions on adjuvant treatments, and sentinel lymph node biopsy should be considered for this population in patients with high likelihood of nodal involvement. Moving on, I would like to address 2 more studies looking for the answer to the eternal question of omitting surgery following neoadjuvant chemotherapy for complete responders. The first of which is from German group, who are very well known with their retrospective and prospective validation trials on this issue. By means of integrating artificial intelligence and vacuum-assisted biopsy, German group managed to decrease the false negative rate to null also for the axillary status, which means via this algorithm, if the biopsy says there is no cancer left, it is very unlikely to find persistent disease with surgical excision. And this deserves great attention to predict a potential subgroup for whom omission of surgery might be possible in the future. The second abstract is a multi-center prospective study from Tokyo, Japan, with an aim to assess the accuracy of vacuum-assisted biopsies in addition to imaging findings for clinical complete responders after neoadjuvant chemotherapy. Researchers used a large core biopsy in 88 patients guided by ultrasound. 82 out of 88 patients were node negative after the neoadjuvant treatment. The accuracy of radiologic assessment didn't reach the desired values of 90% regarding negative predictive values for all tumor subtypes. Moreover, the integration of vacuum-assisted biopsy didn't lead to an improvement to accurately assess tumor burden without an increase in negative predictive value or decrease in false negative rates. For only 12 patients with a clip-marked tumor bed before neoadjuvant treatment, they were able to get a much higher negative predictive value with 90%, but false negative rate is still far from desired with 33%. With the presented results, the authors couldn't support the omission of surgery by vacuum-assisted biopsy for patients with a complete clinical response after neoadjuvant chemotherapy. Last but not least, it was a great pleasure for us to present Oksana's study on ongoing trial sessions with more than 1,200 patients, which attract great attention. And the results will probably shed very valuable light, I believe, on axillary management in terms of the escalation after neoadjuvant treatment. And I'd like to thank all my colleagues from 21 countries who are supporting this on behalf of all Oksana team. And I would like to thank you for your attention.